Hey, y'all. Welcome back to the Yes We Can podcast. Today, I have Dr. Kian Lim on to talk with us about all things pancreatic cancer, about my husband's journey and battle. I am beyond thrilled to have you here today. Thank you so much.
Thank you, Kira. I'm so grateful to be here.
Yes, and welcome back, because you've been on the show before.
Yeah, I remember a few years back.
Yeah, a few years back.
Yeah.
Yeah, and I don't even know where to start, but you truly are one of a kind. Can we talk about who you are, where you're from, your background a little bit?
Yeah, so I went to medical school in Taiwan and came to the U.S. in 2002 to Duke University, where I studied cancer biology. And shortly after that, I came to St. Louis to WashU to be trained. And I've been here as a faculty since 2013.
2013.
Yeah.
Okay.
So it's been a long time.
And you have a family.
Yes, I do.
A wife, and how many children? Two? Three.
Yeah.
And how old are they now?
3 boys. The oldest one is 25, followed by a 19-year-old, and then a 14-year-old.
Oh my goodness.
All boys, yeah.
All boys. Are they studying science and medicine?
No, the oldest one's actually in music school in UMKC, Kansas City. So he's majoring in performance art, majoring in viola.
Yeah.
That's what he wants to do. I fully support that. That's his passion. My second child is currently at WashU in pre-med.
Okay.
He seems to want to follow my footsteps.
Yeah.
And I encourage that.
Of course.
Secretly being excited.
Yeah.
Yeah, and the youngest one is going to high school next year. So.
Yeah. Exciting.
Yeah.
Well, it's funny because a lot of times people forget that doctors are humans and have life beyond their work.
Yeah.
I worked in pharmaceutical and medical sales, so I got to know doctors and helping. It's really helpful to realize you guys are humans too, and you have an amazing, your own personal life. So, we've obviously been connected now since October of 21. For those of you that don't know, we have a lot of new followers, so they may not know our story. But my husband Kyle was diagnosed with stage 4 pancreatic cancer, October 23rd, I believe, of 2021. And Dr. Lim took on his case. And I want to talk more about that, but I want to talk about first pancreatic cancer as a whole. Can you give us some statistics or tell us a bit more about, why pancreatic cancer is one of the deadliest, why there's not enough funding or research happening, and why you chose to go into pancreatic cancer research?
Yeah, so pancreatic cancer is not a very common cancer, but it is unfortunately the deadliest. So we know in 2026, we're expecting about 70,000 new cases being diagnosed here in the US. And then the incidence is rising. And it seems to be creeping towards younger patients, especially females. So we still don't know what exactly is causing it. About 15% of pancreatic cancer incidences, we can attribute it to some genes running in the family.
15%?
About 15%. The remaining, there are some risk factors. For example, patients who are diabetic, patients with chronic pancreatitis, either from alcoholism or for some congenital or metabolic issues that make them more prone to chronic pancreatitis. And other than that, there's not a whole lot of risk factors that's known to be strongly associated with pancreatic cancer. And if you ask me, I think many oncologists will agree that age and something in the environment are the two major factors. Aging, we're seeing patients older getting diagnosed, and younger patients getting diagnosed may have something to do with the environment, the food that we eat, the processed food, and all those things.
Yeah, let's repeat that.
Yeah.
So Dr. Lim just said, and we talk about this all the time, that environmental things in our environment, what we're eating, what we're drinking, those things they think contribute. Right. Now, when you say older population, what age are we talking?
So when I first started out in not more than 15 years ago, it's rare to see a pancreatic cancer patient below 60 years old.
Below 60.
So the average age of diagnosis was around then was 68 to 70. But now I'm seeing it's creeping towards 60s and 50s, and I do have patients in their 30s getting it. And older patients too. We're starting to see more 90-year-old, 80-year-old getting diagnosed. So it seems to be spreading across different ages.
And people often say, well, we have better technology to find it, but unless it's caught by accident, and correct me if I'm wrong, often 9 times out of 10, and maybe those statistics are off, it's caught late stage.
That is correct. Only about 10 to 15% of patients are diagnosed at a very early stage where the tumor was located near the bile duct. People get jaundice, and then that's how they found it. Most of our patients are diagnosed either at an advanced stage, or where the tumor is so big you can't take it out, or when it's metastasized. So we still, at this stage, still do not have a good screening test. It's not for lack of attempt. Many researchers, scientists have tried to develop blood tests, more sensitive CT scans or imaging modalities. Those are not in prime time yet. The major issue is the specificity, meaning how accurate it is. Are you going to create a lot of anxiety and false alarm? So that is a major challenge here, coming up with an accurate test.
So that you're speaking to, on the news lately, there's been a lot about new treatments and early detection. And I always message you when that stuff comes up, or someone sends me something. Yeah. I send it to Dr. Lim and say, how legit is this? Is this really this big of a deal, and making a change? And most recently, there has been something that's been blown up in the news about early detection. Yeah. But you're saying right now it's not zoned in enough. It's not ready to be launched, essentially.
Right. So, but the technology improves every day, and I really am very impressed with how AI has taken over a lot of what we do. So the major challenge about diagnosing a pancreatic tumor is based on how accurate the CT scans are. So we are still at this stage relying on human eyes, radiologists, to look at it and determining whether something is concerning or not. And secondly, how do you follow up on these patients who have one concerning scan? Do you get a scan in 6 months or a year, or how do you follow them? And when you follow them, do you have the same set of eyes that are looking at the same scans every 6 months or 1 year? And the reality is we don't. But AI can solve that problem. So it has this machine learning capability where it can gather mass amount of data and self-learn and improve. So it has the ability to longitudinally go back to any single patient, going back to their prior scan and seeing how things have evolved, even at a very small scale.
Amazing.
That may, in the future, I think, be a way of improving our ability to detect these cancers earlier, especially for high-risk population.
Amazing.
Yeah.
And I have so many questions. There's so many things going through my head right now. So we're going to piecemeal this. But so if someone gets a CT scan and they see something in the pancreas, they have to wait 6 months for another scan?
Yeah, it depends on how concerning it is. We typically go back to their history, and we try to see if there's any prior scans that they would tell us whether this tumor or this lesion has grown substantially over a short period of time. And we also look at that particular scan and how ugly or how concerning it looks. Does it have some of the feature of a cancer? And that will prompt us to do the next step. But if the lesion looks benign enough or suspicious enough, but not to the extent where we need to do an invasive procedure such as a biopsy, we typically follow it with another scan in 6 months to a year.
Okay.
And see how things change over time. But if the tumor, like I said, if it's big enough, concerning enough, it has all these hallmarks of cancer, we then refer the patients over to endoscopy for a biopsy.
Well, because pancreatic cancer moves quickly oftentimes. Isn't that the case?
That is the case.
It's a fast-growing cancer.
Yes, it's a fast-growing cancer.
Yeah.
So it does take a long time for things to accumulate, for them to evolve. But once they form a cancer, they are one of the ones that are known to metastasize very early.
And now, why did you decide to research and go into pancreatic cancer?
Yeah, so when I was in my PhD back in 2002, my PhD thesis was on a gene called KRAS. And this KRAS is at the time, it was initially found in virus, and virus has a different version of the RAS gene that's inserted into human tumor and transform human cells like that. So we later found that this gene is mutated in many human cancers, especially pancreatic, when 95% of them have the same gene mutated. So that kind of sowed the seed for me to wanting to do pancreatic cancer. But later on, following my training, I had gone into lymphoma first in my clinical training, but within a short period of time, something drew me back to pancreatic cancer. So that was around the time of 2010, when the only thing we had was one chemotherapy called gemcitabine. The outcome of patients were dismal, and we didn't have a lot of tools, a lot of therapies to help them. Their survival was around 6 to 7 months back then, in average for advanced stage patients. So I figured, if you want to do something different in your life, so like my father told me all the time, you want to do something different in your life, pick something challenging. That's when I switched. I switched my gear towards GI pancreatic cancer during my training.
Amazing.
Yeah.
And again, correct me if I'm wrong, pancreatic cancer does not attract a lot of new researchers. It's not really an exciting cancer, right? Like there aren't.
Yeah.
Can you talk a little bit more about that?
Yeah, so back then it was really not a very popular cancer to study because there was not much you can do, and the incidence was not as high as the other cancers like breast or lung or prostate. So for the longest time, it had been severely underfunded. So it's not until 2000, later on, during the Obama administration, that there was an act called Recalcitrant Cancer Act, where pancreatic cancer was highlighted as one of the cancers that need more attention.
Amazing.
In terms of research and clinical research and scientific research. That's when things started to get better.
Oh.
We started having more researchers wanting to do it.
Okay.
We are in a better shape than we were before.
Yes.
But definitely, it is still compared to the lethality of how bad it is.
Yeah.
The resource that we put into this cancer, when you try to correlate it with the burden that patients and families have to go through, it is still not enough.
Right. It's not enough.
It's not enough.
In cancer research funding, let's just go ahead and talk about that. So it is not enough. The federal government is still the number one funder of cancer research. Is this correct?
That is correct. So when we talk about cancer research, there are a few aspects to it. We study how cancers evolve and how they behave so badly, being in the case of pancreatic cancer, why they are so resistant to chemotherapy, targeted therapy, or even immunotherapy that are quite successful in other cancer types. And there are also research towards raising awareness, and also research towards how do you treat it better. And so it's broken up to these different aspects, and the major funding source is still the National Cancer Institute at this stage. There are a lot of pharmas that are going into developing drugs and doing more research. But this is a fact that a lot of drugs that were tried on pancreatic cancer traditionally have failed. So there are very few companies, until recently, had wanted to really go into pancreatic cancer research. That's my interaction with a lot of pharmaceutical companies. So things are getting better, but I wish they were better than right now.
Right. Yeah. They are getting better. And so let's talk about, so basically what we're saying is there's not enough funding. The NIH is the arm of the government that then supplies.
That's correct.
You write grants, doctors write grants, which is something that I learned about while Dr. Lim was treating my husband, was that these researchers spend so much time applying for grants, so much time. And the NIH, from my understanding, only looks at grant applications 3 times a year.
That's correct.
3 times a year. Back when Kyle was diagnosed and battling, 1 in 10 grants were then funded by the government.
That's about right.
And we're not talking about the whole study. You're talking about just some money, right? Okay. And now it's about 1 in 20.
Yeah, it was 1 in 20, but now it's a black box now.
Black
Because
box.
the way they fund the NIH grant, we call it the research grant, R01, they are now no longer looking at a number right now. So usually in the past, when you apply for grants, you get a score. If you're in the top 10th percentile, you have a high chance of being funded. You have top 5 percentile, you definitely get it. But now it's unclear. You could be in your 5 percentile, but then the NIH will look at other factors. For example, the geographical location, which is good for us, and how much funding this person has already had, and also what kind of research you're proposing. And so there's a lot of other factors that is not very clear to us that are coming into play right now. So the whole overall the funding line is still below 10 percentile. It's just the way they choose within that pool. It's a little bit unclear to us now.
And a lot of these researchers have some really promising things in their labs.
Yep.
Correct? So that is why private funding and fundraising is incredibly important, and why I've continued to talk about it and drag Dr. Lim with me everywhere. He has been to countless different things to try to, help him create more funding for pancreatic cancer research. So Dr. Lim is very well respected in the pancreatic cancer research world. I have talked to a lot of physicians and done a lot of research, as you probably gathered. And I always say it doesn't have to be one person funding everything. Although I would love if those of you in the top 1% would give us a ton of money, because we could really move this cancer along. But if everybody gives a little bit, then we can move some mountains, right? And money is what moves mountains.
Exactly. Yeah, that's the reality. You need funding to buy reagents, to keep people in the lab. And in recent years, the important thing that I've realized this all along, but it's becoming more important, is to keep the next generation of researchers, keeping them in academia and doing important work. I'm sensing, I think many people over the country are sensing the same thing, that we are starting to lose one whole generation of researchers because of funding challenges. So
that's scary.
Yeah.
And you mentioned last time we met, you had mentioned that some lot of labs are closing down because of lack of funding.
Yeah.
Even the threat of lack of funding.
Right. The threat of lack of funding, and when the money dries up, how do you go on? You have to close down the lab. And a lot of them are physicians also. They'll have to go see more patients, and there's a point of no return.
Did you know going into this line of work that you were going to have to be, did you know how challenging it was? And did you know you were going to have to be a grant writer and going on and asking people for money and fund? I mean, did you know that going into it?
Yeah, I knew this going into it. I was at the National Cancer Institute as a fellow. At the time, we didn't have the right grants if you are within the NCI. So when I decided to take on a job at Washington University, I knew this coming in. So I was been writing grants, seeing patients, doing research, teaching, or doing all of those at the same time. It's just that the funding part has gotten increasingly challenging over the years. The amount of money that we get from each grant is not catching up with the inflation. So reagents, everything is so expensive. The things that we can do with the same set of amount of money, it's actually less compared to 10 years ago. So,
well, that's what I was going to ask. The dollar 10 years ago and the dollar now is not stretched like it used to.
Exactly, yeah.
So, yeah, there's so much going through my head. But can we talk about Kyle for a little bit? When he was diagnosed, it was during COVID. Our kids were 4, 2, and 11 months. He had been struggling all year. He had symptoms all year. By the time we found it, it was everywhere, essentially, right? Tail of the pancreas, it had wrapped around the colon, I think liver, lung, I mean, everywhere. I don't think they thought he was going to make it initially. And from my understanding, correct me if I'm wrong, Well, first and foremost, he had to get a stent put in because his tumor had wrapped
around the colon.
around the colon. And so you had to find someone down at Siteman that was willing, able, and trained to put a stent in his colon to open it up.
Yep.
And that doctor was nervous about it.
Yeah.
Right?
Took some convincing.
Took some convincing because if he perforated his colon, it's over.
That's correct.
So this doctor did it.
Yep.
And then you took on his case. From my understanding, no one else wanted to take on his case. How did that go down? How did that go down?
Yeah. Within the GI medical oncology group at Washington University, as you can imagine, GI oncology is not just one disease. You have gastric, colon, biliary tract, liver, and small intestine, and all those things put together. So I happened to be the pancreas cancer person back then. The only one. My mentor had left at the time to pharma, so I was the only one doing pancreatic cancer research. And
wow.
So and the inpatient team, I remember Kyle was in the hospital, reached out to me and say, hey, could you, Kyle's here and there's no oncologist. We have inpatient oncologists, but there's nobody to really, dictate what to do. That's where I came in. Without second thought.
What were you thinking when they presented his case to you?
Yeah, like every case, I looked up the patient's name and information and all these findings, scans, blood work. One thing that really, I still remember that feeling that really shocked me was the age. And the age, it's not just one patient that I see when I see the name. I imagine, what's going through in the family and how shocking it must be for him and also for the family.
Yeah, because he was 47 at diagnosis.
Yeah.
And I think that's unique. You look at every patient individually. I mean, I'm not sure every doctor does that.
Well, I hope most do.
Yeah, hopefully.
Yeah, I'm
but
one of them.
I don't know. So you saw how young he was. You saw how bad it was, but you thought we can do something.
That's right. So remember, the first thing we needed to do was to alleviate or relieve the blockage. Otherwise, it would be challenging. And I knew that Kyle wasn't going to be able to eat, so we managed to get in some IV nutrition. That's when we started thinking about, okay, we got to get some therapy in and just try to turn things around. Yeah.
Have you had patients come in with the pancreatic cancer wrapped around the colon like that before?
Oh, yes, all the time.
Oh, really?
All the time.
It's
yeah.
common.
Not as common as liver metastasis, but this is one of the more common presentation. Yeah.
It's just bizarre.
We actually have one right now in the hospital.
Really?
Going through exactly the same thing.
Really? Young?
A little bit on the older, more mature side,
Yeah.
but very similar.
Okay. Wow.
I see this every month or two.
Wild.
Yeah.
So, yes, Dr. Lim, we went right to the hospital, put a feeding, not a feeding tube, PICC line. So he did not have a port. Did he ever get a port? Maybe towards the end.
Later, yeah.
And we had to drain his belly because he was completely clogged when we found it. And so went into the hospital. And I remember some of this very vividly, but some is, obviously a little fuzzy. But we got out of the hospital, and I know we had a week until we were going to be able to see you in the clinic. Did he get chemo? Do you remember? Did he get chemo in the hospital that first time?
We gave him some chemo in the hospital.
Okay.
After we were able to get him fluid and nutrition, and he looked well enough.
Yeah.
So we actually started one dose of chemo in the hospital.
It was FOLFIRINOX.
FOLFIRINOX.
And correct me if I'm wrong, as of today in the U.S., there are only 2 standard of care treatments.
Correct.
That was the same 5 years ago. Well, 2021, yes. So then Kyle decided he wanted to go to Montana to see his family before he got more chemo. So we got on a plane, flew to Montana, and while we were there, the tumor did the same. He got reconstructed Do you remember that? And so we went into the emergency room, and no one in Bozeman, Montana, surprise, surprise, was trained to put a stent in. So we had to take an emergency flight home. And I believe that same doctor had to go back in and open him up again.
Yep.
Yeah.
With another stent.
Another stent.
Yeah.
Oh, my Lord. So then we come in. I believe we were hospitalized for a while then. So then we come into you, and I remember you coming in with multiple people. I don't know, other doctors. What?
In the hospital. Yeah, usually.
In the hospital. Okay.
In clinic?
In the clinic.
Okay.
Yeah.
Yeah, so they were usually with fellows, trainees, residents, and nurses. Yeah.
And I remember you saying he was really jaundiced, yellow, and I didn't see it.
Oh, yeah.
He was really yellow. And I didn't see it.
Well, so when you look at patients with this cancer a lot, you tend to get some sense.
Yeah.
Yeah, so.
Well, plus I was with him, so maybe he was yellow, but I hadn't seen it over time. But I just remember you guys really shocked about his coloring. And so then your thought was, okay, we're going to start with fulfirinox, and we see how that goes. And I don't remember, we were in and out of the hospital multiple times.
Yes.
I mean, a dozen times. I don't even know how many. Were you thinking this man's going to die? We're just going to buy him some time? What was going through your head?
Yeah, at the time, we knew that, and we still know that with patients with metastatic pancreatic cancer, all kinds of chemos you're just trying to prolong their life. But there are some outliers, people who are like Kyle, younger, good organ function, and otherwise doing well, could have gone on for a while. So at the time, we know the response rate for fulfirinox was 30-some%, with another 50% of patients having stable disease and not shrinking or maybe growing a little bit. So those are numbers that we had, and so it was more like, let's just talk about it, talk about possibilities, and do it, and then we just keep our fingers crossed.
And after a couple months, and again, I mentioned this is during COVID, because Kyle was a nervous Nelly. Do you remember that?
Yeah.
He was anxious. He was nervous. He was already somewhat of a hypochondriac, but he was nervous about everything. So we had to try to keep him calm, and everybody masked, and he wouldn't even let our children touch him for a while. It was, there's so much that went into this. So he did fulfirinox for a couple months.
Yes.
Right? And then you guys scanned him again.
Yes.
And he had a mixed response.
Correct.
Can you explain what a mixed response is?
So mixed response is where when you look at a patient with metastasis would have multiple tumors in their bodies, including the primary pancreas, some in the liver, and some in the omentum. I forgot the details, but I remember that some of the tumors got bigger, some tumors got smaller. So that's why it's a mixed response. But overall, when I was looking through the entire picture, things are not getting better. That's when we decided to switch.
Do you remember what we looked at his CA19-9 was his tumor marker. I mean, you've seen a million patients, but do you remember how high it was?
I don't, in the hundreds, but it was slowly creeping up.
Yes.
During the fulfirinox. Yeah.
Right. And he at that point, he wasn't eligible for immunotherapy or any of the studies happening.
Clinical trials, yeah.
Because why? Because of the type of the cancer he had, or he was too far advanced?
Yeah, because of at the time he was not strong enough, and there were a lot of blood tests that he had that didn't meet the criteria for a clinical trial.
Okay.
And he was on TPN at the time.
That's
there was
right.
also a contraindication for a lot of clinical trials.
So TPN is basically liquid nutrition.
Liquid nutrition, IV. Yeah.
I don't know how I could forget that, because he was on TPN for a long time.
Yeah.
So then after a few months, we found that it was mixed response. So you wanted to switch to Gemzar. Is it Gemzar or
Abraxane.
Abraxane. So that is the second line of treatment, which Dr. Lim had mentioned, fulfirinox being the first line. In the less than 36%, correct me if I'm wrong, less than 36% respond.
Yeah, something like that.
You said 50% respond, but 36%
No, it's 32
shrinkage.
partial response we look at the data, 32% of partial response, but another 50% or so stable disease, no change.
Okay.
So overall, we would expect, that it'll work for a while.
Okay. But then the cancer learns the chemo, learns the
Right.
treatment. Okay.
So some of the cancer responded, some for Kyle, some did not at all. So we saw that too in about 20-25% of patients that after 4 rounds, nothing changed, or things would get bigger. So,
Okay. So then Gemzar Abraxane, even fewer patients respond to that.
correct.
Okay. So that is the point in which I looked at you and said, what else is there? Do you remember your response?
Yeah, not much, but I happened to be doing some research in the lab, and we had this cocktail of Gemzar Abraxane plus a pill, which is an inhibitor towards an enzyme called IRAK4, plus immunotherapy. So at the time, the study was just published, and we are still in the phase of getting the drug company to sponsor a clinical trial, and that's what we talked about.
And I said, what does it take to get from lab to human into Kyle's body? And do you remember your response?
I should remember. You got to remind me that.
I will remind you. You danced around the issue, and I eventually got you to tell me that it takes money.
Yeah.
And you explained that you had already gone to the FDA, the NIH, to submit the study for funding, and they pushed back for needle size. So there was a difference in injecting the mice. Needle.
So we had, at the time, we had already submitted an R1 grant, which is the NCI funding for a clinical trial. That's the name of the grant. We had submitted it twice, and both we got very close, but we didn't get to the funding range. And some of the criticisms were very minuscule, like the designs, and more importantly, I remember the whole idea about what I do is we believe that tumor cells are inflamed. Tumor cells are inflamed, and that kind of inflammation is bad. It's a bad inflammation that's suppressing the body's immunity. So at the time, that's still a concept that's still evolving. It's quite new to the field. And despite what we did in the mouse models showing that that's the way to make immunotherapy work, some reviewers were not very convinced. So those are the issues of why we didn't get the funding.
Yes, and so that's different. I'm so glad you brought that up, because not a lot of researchers are looking at cancer cells this way. This is something that you're doing that's not the majority of cancer researchers, right? And the study was doing well in those mice, correct?
Correct.
It was getting rid of the cancer, if I'm not mistaken.
Yep.
Okay. So then I said, in my mind, I'm like, okay, how do we get it from lab to human, being my human? And you finally admitted that it was funding. And then I asked you how much. And again, you skirted around the issue. And I said, no, Dr. Lim, you said, I can't, Kira, you don't need to worry about that, or something of the sort. And I remember thinking, and I don't even, probably saying, but it does matter. Or we're fighting for our life here. So tell me how much.
Yeah, and R1 funding typically we ask about $2.5 to $3 million to run a whole like 60 patient clinical study in order to get an idea whether or not it really works or not.
So phase 1 study.
Yep,
50 to 60 patients.
Phase 1 and 2 combined.
Okay.
Yeah.
So in my mind, I'm thinking, okay, I think I looked at you and said, I will find you $3 million. Do you remember that?
Yeah.
And what were you thinking? This woman's crazy?
No, you're going through so much with Kyle and with the kids. I'm like, I don't want you to burden you on that. We'll continue to write grants and try to find companies to, the pharmaceutical company was a small one. They didn't have a lot of funding, but they're willing to give us a drug, which is one of the biggest barrier in running clinical trials. You need people, you need somebody to run it, you need an infrastructure. We have all of those, and you need the drug, of course. We have all of those except for funding. So that's where we were. Yeah.
So, and that's just, you're seeing patients. How many times a week? How many clinic days do you have?
1 day.
One clinic day?
1 clinic day.
Wow. And you're doing research all the other days, writing grants all the other days. Okay. So I say to you, I'm going to find you $3 million. And your response was, you don't have to do that. And I said, well, I do. Because in my mind, if we could get you $3 million as soon as possible, you could start a phase 1 study, and Kyle would hopefully be one of those patients. So we immediately started a fund, and this was not Dr. Lim encouraged. He was, what I would say is taken back. And so then we started a fund, and Kyle continued Gemzar Abraxane. And we started a fund. We did a fundraiser. We raised $200,000, I think, at True Fusion before it was the gym. Remember, down at the Foundry?
Yep, I remember that.
You came and spoke.
Yeah, I remember that.
We had tons of donations. We did a paddle raise. It was over $200,000. And I contacted every pancreatic cancer organization I could find, wrote, email, called, because I was trying to figure out how do we get this funded as soon as possible, because time is of the essence, right? Kyle's cancer is growing.
Right.
I don't remember, was he responding to Gemzar Abraxane? I think so.
So, we have to, it's a long time ago. I think the memory is fading away from me.
Yes, of course.
So I remember at the time when we were doing that, because I couldn't get the trial ongoing, so we actually initiated a compassionate use for Kyle. It was one patient protocol, and we got our leadership at WashU to support it. They're incredibly kind and understanding, and we got the drug company to provide a drug. So Kyle got one cycle of standard Gemzar and Abraxane, and then he got onto the pill and the immunotherapy.
Well, let's talk about that. So someone sent me your study, your published study.
Yeah.
And I was in medical sales for 10 years. So I read this study and looked at who the manufacturer was of the inhibitor, because I knew that's what we needed. It was Aclaris Pharmaceuticals.
There were two. One is Aclaris,
and one is
the other one was Curis.
Okay, but Aclaris is what I remember. So I went on my social media and said, who of my people knows anybody at this company? I'm refreshing your memory, maybe. So someone I worked with and volunteered with, so we knew each other personally, sent me the name and cell phone of the founder of that company, Dr. Neil Walker.
Yep.
So then I called him and told him our story. And he was the one that said, had you heard of compassionate use? And I think we had talked about compassionate use, but my concern was that it was going to take too long. We were going to have to jump through a bunch of hoops, cut through some red tape. That would be too long. And he said, hold on, I meet with my board on Monday. If we get a unanimous yes, then we'll allow Dr. Lim to use that drug. And he contacted you then, right?
Yeah.
And said, this crazy woman is calling me? Something along those lines?
Yeah, not crazy woman, but
somebody.
Yeah.
So then I went online and looked at his board, and number 2 listed on his board, I worked directly under in my previous company, Bill Humphreys. So I call him, and he said, I'm going to do my best to get everybody to say yes. I don't know how long after, but you then must have called Curis and said, this is what's happening. But somehow both of them said yes.
Yep.
Right.
That's correct.
And so then it was a race. Which company could get you the inhibitor first? Is that correct?
That's correct.
And Curis was able to get it to you.
Yep.
So then you have to create a study of one, submit it to WashU. I don't know if I'm allowed to say this or not. They said no initially.
They wanted more information and more data, and they're concerned about these being combined with chemotherapy, which has never been done before. It was given to patients with lymphoma. It's just one drug. So they're concerned.
So then I went online and found out who said no and called his office and talked to his receptionist and any nurse that would talk to me. I got his clinic days. I was planning to go sit in his clinic. I had printed off pictures of our family. I wrote him an email. I was going to, I wrote him a long letter. I was going to wait until he saw me. I also looked up his address, because you can look up addresses online, and I was going to leave it at his front door. Wow. But I told you I was going to do this, something along those lines, and then you called him, and he changed his mind.
Yeah.
And the answer was yes.
Yeah.
How did you change his mind?
Well, you just talking. I don't remember. It was just talking and explaining the situation. Maybe
Yeah.
you had talked to him already. I don't know.
Yeah.
Maybe
Well,
you had talked to him already.
I had never talked to him. I wrote him an
Okay.
email. I talked to all his staff, but I never talked with
Maybe
him.
he got an email.
Yeah, maybe.
Yeah, yeah.
So then it was on, right? And I remember you being so excited
Yep.
that this was happening. And Nancy, your nurse at the time,
Oh yes, Nancy House.
yeah, she's miss her so much. She's
Yeah.
great. She's doing great.
Yeah.
Little side note, because her husband died of pancreatic cancer,
Gastric.
gastric cancer, so similar. After the fact, not while we were treating Kyle, I don't think. So then what? So then I don't know how long it was, a few weeks, a month, I don't know, but we were able to start this study
Yes.
and it started working.
Yeah. So I remember I actually went back and looked at all the data and the tumor marker and so Kyle had one cycle of standard just gemcitabine, maybe 1.5, something like that. And at the time the tumor marker was still plateau, not really budging. And I also plotted his weight. He was not gaining weight at that time. And then we started giving the immunotherapy and the experimental drug called IRAK4 inhibitor. And about a couple of months after we started, that's when we started seeing the tumor marker going down. And he's starting to gain weight, and the tumor started shrinking. So that's encouraging. Yeah,
Very much so.
Yeah.
And let's talk about real quick. So the inhibitor, this is how I explain it. Softens the coating or reduces
Yep.
the inflammation around the cancer cell,
That's right.
which allows chemotherapy
And immune cells.
and immunotherapy to
Yep. Yep.
penetrate the cancer.
Yes.
So are you allowed to use less chemo or it just works better?
So you still need, for this whole cocktail, you still need some chemotherapy to really hit the cancer cells, along with reducing the inflammation. You still need to hit the cancer cells. So it's basically something that leads the way. Clear the path, and then the IRAK4 inhibitor will do a better job. And that's the last thing that comes in is the T cells, the immune cells. So I think that's every treatment has its own role in this cocktail.
Right. And immunotherapy has been working well in cancer, different types of cancer,
Some
correct?
melanoma.
Melanoma?
And some cancer, yes.
Okay. So we were able to get Keytruda
Yes, we got Keytruda
through Merck, correct?
through Merck.
Yes, through compassionate use,
Also compassionate use.
which is amazing.
Yeah.
I've never written to them or thanked them, but somehow I need to.
Yeah.
So, and you know, Dr. Lim, I never thought Kyle was going to die. I did not believe it. And I don't remember anyone telling me his prognosis, but I did not believe he was going to die. And so when he was getting better and his tumor marker was shrinking, we were elated and we're like, this is God's answer. You know, we have been, wearing shirts that say expect miracles and, doing all sorts of stuff, asking for prayers and continuing to find fundraising for Dr. Lim and his team, because we knew that Kyle's not the only one. There's so many others, and it's affecting patients younger and younger. And it gave us something, me in particular, something to focus on in addition to, my husband. But I also was fighting, trying to keep my head above water and not fall into this deep depression while my husband was being treated.
That's tough.
And so I just kind of put my nose to the ground and went for it. So then his tumor marker continued to go down. Kyle started gaining weight. There were fewer hospital visits. We ended up being able to go to Disneyland with the kids. Our nephew, Kyle's brother's son, was drafted in the NFL. I don't know if you remember that, but that's all Kyle worried about was Troy Andersen, his nephew, was drafted in the second round, number 58 overall to the Atlanta Falcons. And Kyle was that is what he focused on. It kept him going. And we got to go. His tumor marker continued to go down and he continued to get better and stronger. And we got to go to a couple of Troy's games.
That's great.
Yes, it was, awesome. And by the end of that year, his tumor marker was so low. Was it no evidence of disease? Do you remember?
Yeah, at one point, we'd look at the scan and it was read as almost normal. There was no, the previous lesion had disappeared and it was almost like a normal scan.
So it worked?
So it's just one patient. I certainly would not have expected that with just gemcitabine. It's extremely rare or unheard of to have that kind of response. And I do remember Kyle ran into some immune complications. At that point, we had to hold everything, and he continued to respond for a prolonged period of time without chemo or anything. So that gave me some confidence that maybe the immune system has been activated. So,
and we went through the holidays, and he didn't get much treatment over that time. And then the beginning of 2023, from my recollection, he started getting sick. We ended up back in the hospital. I don't exactly remember what happened, but we had to spread the treatments out.
Right.
Because his body couldn't handle the treatment.
Because of the immune. So he had a lot of diarrhea from the immune overactivation. We did some tests, and he had some colonoscopy. So, and then the colon had previously been, injured by the tumor. So at the time we decided to hold treatments or space it longer. Yeah.
And that continued for a few months. Then, and I honestly don't remember, was it that his tumors grew back, or was he just too sick to get treatment? His body just...
Yeah, so at that time, he started you mean at the final stage?
Final stages, yes.
Right, he had a blockage again. So I believe it had to do with the food, that he was supposed to be on low residual diet, and then maybe the inflammation happened again, or a tumor came back to some extent, that there was a blockage again. So then things didn't get through. The surgeons couldn't do anything, and the person who did the stent said, we put 2 stents in, there's no way we can put another stent in. So that's when things started to go downhill. And at the time when we look at the scan, there was still very little sign of cancer actually coming back and occupying the body. So there was some evidence of that. It could have been inflammation or some tumor, but who knows. But so it's unfortunate.
So it was food that was blocking him.
Yeah, that was one of the main theory. It was something that's blocking the passage of the food through that part of the colon.
I mean, I remember the final stages when he was in that hospital, and we were trying to figure out what to do.
Right.
The doctor's there. You and I were on the phone communicating. Do we try more chemo? Do we try another stent? Do we put a tube somewhere else? And I just remember finally the doctor on call saying, the anesthesiologists are not comfortable putting him under.
Right.
He won't make it.
Right.
And that was it. But I remember you even saying, look here, we can try chemo again. And it was just, it was too late.
Right.
And so it was,
too late,
I mean, and how do you, as a doctor, how do you handle that? I mean, you obviously in pancreatic cancer, you deal with it a lot.
Yeah, it's still not easy, but you have to remember that, of course, my heart breaks every time when this happens. It still does. You don't get immune to that. You just try to move on. You have to remember that you have so many patients counting on you, counting on your head being clear and having clear plans for everybody. So that's what I keep reminding myself. But of course, we're, after all, like I said, still human. And my heart goes out with every patient that I lose, and with their families too. Yeah, it's hard for me, but it's harder for you and the family. It's harder because you have to go through that. The only thing I can do is just be a small part of the whole journey and be there.
A big part.
Yeah.
So I always say you gave Kyle an extra year of life because of that treatment, because of the research that you had done.
Yeah, so I don't know. It's just one patient, but we are starting to see more and more patients using the same, we call it the Andersen regimen, Kyle's regimen in other cancer. We're starting to see some hope that it's actually maybe real.
Right.
Yeah.
So now we've continued to raise funds for your lab, and Kyle's treatment is in 30 to 40 other patients now?
Right. So we have launched a few different clinical trials. So when we are not able to get the whole package, including the drug and immunotherapy, into clinical trial, so we talked to the NCI, and they have ETCT, an experimental therapeutic network, where they will take really good clinical trial concepts, they call concepts or proposals, and they'll run it. So we went through that route. It got immediately accepted, and they're running it, but without immunotherapy. So it's gone into about 30, 40 patients right now.
That's right.
And our goal is to collect data from these patients and to justify adding immunotherapy later on, which we had already done with Kyle.
So was it Kyle's data that you brought to the NIH?
Yes, I included Kyle's data in the NIH, and they took it right away. So other than pancreatic cancer, we also had some evidence that this could work in bile duct and gastric stomach cancer. So for these two other cancer types, immunotherapy is already in the whole regimen. It's chemo plus immunotherapy, and all we needed to do is just add one drug. And
The inhibitor.
The inhibitor. And we did that already for stomach cancer patient that Nancy's husband died of. And we are pleasantly surprised. We have enrolled 20 patients so far, and 5 of them had complete response, meaning just like when I saw those, I was like, this is Kyle. This is like Kyle. So all the tumor disappeared.
Were these stage 4 patients?
These are all stage 4 patients.
Okay, so stage 4 meaning metastasized to another organ.
Right.
So he got the Andersen regimen. Out of 25 had complete
response.
Complete response. No
Yes.
evidence of disease.
Yeah, for prolonged. The first one who had a complete response is going into 20th month right now. Still complete response
Here at Simon
here, Simon.
in St. Louis.
Yes, and we had the other out of 20, 5 complete response. We have another 12, 13 had partial response, meaning tumor shrinking, and we're hoping that with time, just like what happened with Kyle, you don't see complete response right away. They continue to shrink over time to the point when you can't see them. That's when you call complete response. We're hoping that it would happen to the other patients too.
And not very many non-responders, am I correct?
Correct.
One or
2 patients did not respond, but it was based on when we call response, what you do was you, out of that 20 tumors, you highlight 2 or 3 of them, and you track them over time. So for these 2 other non-responders, the other tumors, they actually had a mixed response. So tumor got smaller except for those 2 that we highlighted at the beginning. They got bigger, but the others got smaller. So, but still encouraging enough for us.
Yes.
Yeah.
And they're looking to put this in colorectal cancer patients as well, potentially?
Yeah, it's already open.
It's open?
It's already open.
When did that happen?
About 3 months ago.
Okay.
Yeah, in colorectal cancer patients as well. Yeah.
Which is?
Yeah, so far it's still early stage. We don't know yet. And the biliary tract cancer, we opened it about a month ago. We had 3 patients treated. One of them is my patient. And after the second dose, all her cancer pain went away. So we haven't scanned her yet. I don't know, but she told me that she's no longer using pain medication. So
wow,
that's encouraging.
Because
We'll
Kyle
see.
was on fentanyl the
Yeah.
entire time. And God knows what else. I don't even remember.
Right.
So bile duct cancer, I've recently been hearing about that. Is that
Right.
on the rise?
That's also on the rise.
Yeah.
It has very similar in terms of how they look and what genes are mutated. There's a lot of overlap with pancreatic, and they're both very difficult to treat, and both are usually diagnosed at later stage,
Late stage, yeah.
And with no good prognosis.
Okay, and your pancreatic cancer patients that have received the Kyle regimen have similar results as the gastric?
So not as good because we're still lacking the immunotherapy component. And
Why won't they allow you to use an immunotherapy?
Yeah, because they are wanting to do it stepwise. Just prove to me that with this 20, 30 patients, you are seeing what you expect to see. And then if you can justify that, we're going to add it on. So we are still in that process of proving it to the NCI.
So the inhibitor and chemotherapy.
Yep.
And you're seeing a response.
So far, our results are encouraging. These are patients who have gone through FOLFIRINOX. In a second-line setting, gemcitabine and Abraxane alone, you are expected to see only 10% of patients responding. And they typically should last about 2.5 to 3 months before you have to switch regimen. So we are seeing more encouraging results, but definitely nothing like what Kyle.
Because we need that immunotherapy.
That's what I think it's missing.
So what are next steps? What are you, and obviously funding, and on Kyle's third anniversary, April 3rd of this year, 2026, we started another campaign to raise another $1 million, because I feel very strongly about getting you $3 million, as I promised you verbally. And I know you always are like, Kira, you don't have to do that. But I do. I feel called to do it. Last year I didn't do much fundraising. And I mentioned to you that I had really bad anxiety and depression, and grief hit me like a ton of bricks. I'm much better now. Started my podcast again and decided that it was time. So I met with you and your team. And after meeting with you, felt called to start a crowdfunding page, something that Siteman is launching, a soft launch. And so now myself, a couple other widows that their husbands have been treated by you, and Jamie Luth, whose husband currently has cancer, pancreatic cancer, are locking arms to raise that $1 million as soon as possible. Because as quickly as we can get money into your lab, you can start adding patients, correct?
Yeah, so we are doing a few things now. One will be to expand on what we gave Kyle, to try to expand it, and to see whether the drug will work together with the daraxonrasib, which is a new, soon-to-be FDA-approved KRAS inhibitor. And we are trying to expand horizontally to different cancer types. And importantly, we are also opening new directions as well, other than, if you look at the inflammation pathway, it's not just that one target. It is, I chose that because I believe it was a central target, but there's actually a few of them that are central. So we're working on those targets as well in pancreatic, so that if this stops working, what is your backup plan for these patients? So that's the way I formulate the whole treatment. It's not just one. And how do you incorporate new therapies into what you're doing? So those all requires preclinical work. And along the line, you've met with some of my members because of you and what you've done and what you empower us to do, is to really persuade and attract talents to come to my lab and to work with also David Donato's lab, who is my close collaborator and fantastic, brilliant guy. We are basically joining forces, working together, and attracting and keeping and nurturing this newer generation of researchers who are committed to pancreatic cancer. And this is something that in recent years have become such a success, thanks to you.
Well,
that we are starting to get phone calls from patients all across the country. Can we come here and also not only patients, but researchers, junior faculties who are in Ivy Leagues or in other places that, can I come here to work with you? And that's really exciting to know. Usually 10 years ago, it's the other way around. We lose people to the coast, to the Asfield. Now we are seeing people wanting to come to us. So I think we are really making a difference here. And like I said repeatedly, I hate to be a broken record. If you look at pharmaceutical clinical trials and big consortiums, we are quite isolated geographically. We are not like New York, Boston. You have like 8-9 major centers there forming an alliance, and all we have is ourselves. And we need to do something better so that patients don't have to come here, go to Lambert Airport, and then go to Houston or New York. They can just stay here, closer to home, knowing that they're getting one of the best treatments in the country that the country can offer. So that's, I think, is more meaningful, is not equally meaningful to us and my team. Yeah.
And now, so we've raised, let's say, around $2 million. So, and that, it is a lot of money, but it's not.
Yeah, in the clinical trial world, it's actually not a lot. Yeah.
Right.
Right.
It's helping, for sure.
For sure.
And it's getting the promising treatments into patients. But the reason I always talk about, I haven't started a 501(c)(3). We have a fund just for you, because you don't have to go through a bunch of hoops. You don't have to write grants to get the money that's gone right into your fund.
Yep.
And all those other organizations that are awesome and have moved mountains, but those bigger organizations, it's a big pile of money and then you don't know where it goes.
Right.
But when you support, and maybe it's not pancreatic cancer research, maybe it's another research, but I've said this from the beginning, if you can find a researcher that is having success in their lab and donate directly to them, the needle moves faster. More patients get treatment faster.
Yes. So it depends on what that research is doing in the lab.
Correct.
And Kira, you and I share this all the time. We have cured enough cancer in mice.
Mice, right.
And having a clinical head allows me to basically move things back to patients. So the fund that we raise, yes, part of it will be to support what we do in the lab in finding new treatments. And most of the money will go back to patients. And like I said, clinical trials is not cheap. You got to pay for research associates, data collection, safety, regulatory components, all those things will have to be paid for by some funds in order for patients to be treated safely and under some close supervision, like from WashU. So fund is limited, but we have found ways, at least here at WashU, to do things more efficiently so we can do a lot more with less resource. That's a kind of survival instinct. That's a kind of a talent we developed over the years. We can do a lot more with the same dollar as my colleagues can do at the coast. So, which is something that I think speaks to commitment of our team and WashU and people that are in this together.
And you. And I'm not the only person around St. Louis who's lost a loved one to pancreatic cancer who is an advocate and continues to fundraise. I know some of those families. But what do we need right now, Dr. Lim? Like what, $1 million is going to help you get into, but what is the next step? How much money are we talking? And you're, if someone were to write you a check.
So we're really grateful, definitely, but the battle doesn't stop with that $1 million. It continues. New treatments are coming in, and that warrants new research in the lab and new clinical trials to try to incorporate like the IRAK4 inhibitor into the new KRAS drug nowadays. We really need some data to support that concept. So as long as the cancer is still around, there'll be no end to what we need. But we really appreciate it. And currently, the economic situation is not great, and everybody's struggling financially. So what we try to do is to find resources from many different places. We continue to write grants. We work with you, and we are really appreciative. And we talk to our leadership as well. And we continue to work with private foundations as best as we could to try to find money to keep us going. So if we are given $1 million today, what we can do is immediately expand on what we're doing with the Andersen regimen, for example. We can enroll more patients. I would quickly collect and analyze all the data from the clinical trial through the NCI and quickly justify that we need to have the immunotherapy component as quickly as possible. So that is still a limiting step that we have right now. The trial is ongoing really rapidly throughout the country. There's a lot of need. But when things are going through the government, there's a little bit of things that are out of our control. So definitely it helps to have more resources.
Yeah, and for everybody listening, you can write it off on your taxes. If you are, a God-fearing person or, I guess a Christian, read the Bible, it talks about tithing. A lot of people feel awkward about talking about that. It's something I've been praying about for a long time, but it highlights the fact that God has blessed people with resources, right? And our job, we're in this world together. And our job is to take care of each other. And so I really encourage people to look at their finances and think, am I giving away to church or to charitable organizations? am I making a difference? Because I believe God blesses us. And, with that money, if we can bless other people, our world can change truly. And again, I'm not talking about one person funding everything, but if everyone gives a little bit, it can really move mountains. And again, when you donate to Dr. Lim and his team, you can write it off on your taxes, and it's happening. It's getting drugs into patients as we speak, which is huge, and I do it for Kyle's legacy. I do it for my children so that they see and know that losing their daddy and the sacrifice of their daddy is hopefully helping to save so many other people's lives. They know Dr. Lim very well. He is a household name. My kids, I told them you were coming on the show today. And they're like, oh, Dr. Lim. So, and we're planning to do a benefit concert in the fall. Some of Kyle's colleagues at Edward Jones, who, by the way, have been very generous in supporting this treatment, have formed a band, and we're going to do a benefit concert. So that's coming in August. More information on that to come. But real quick before we wrap up, I want to talk about, there's been a lot of excitement about new treatments in pancreatic cancer. One in particular starts with the letter D. I can't pronounce it.
Yes. It's called daraxonrasib.
Okay. And it, can you talk a little bit more about that?
So 95% of pancreatic cancer tumors has a mutation in a gene called KRAS, which is also the gene that I studied in my PhD, which is also why I'm continuing on the same line of work. For the longest time, since it was first discovered more than 40 years ago, people didn't think that we can have an answer for it. How do you shut it down? So recently, a company called Revolution Medicine developed a clever way of shutting it down. So they basically are able to develop a drug called daraxonrasib, where it will go into the tumor cells and identify this mutated protein, defective or mutated protein, and glue it to a junk. So you basically render this protein non-functional. So it's proven to be very effective compared to chemotherapy. It prolonged the survival of patients by twofold. So patients who were otherwise having gone through one line of chemotherapy, if you give them a second line, they typically last for about 6 months. Now you're looking at 13.2 months. So this is a long awaited non-chemotherapy option for 30, 40 years. It is exciting, but similar drug has already been approved or found to be effective in lung cancer and colorectal cancer. So we are trailing behind. It is exciting, but it is still, in the end, not a cure. So, but it nonetheless gives us a new tool that we can build on. So all these studies that we did in the lab, and including people around the nation, we previously were building our idea on chemotherapy, but now we have a new backbone that we can build upon, and hopefully they'll be much more tolerable and it'll be more effective.
Okay.
So that's the way we had it.
So a single drug. Whose research is that? Where did that come out of?
It was from a company, a scientist, a biochemist actually talked to him from Revolution Medicine.
Okay.
So they were using actually an old concept, and it's not a entirely groundbreaking new concept. It was an old concept that he was just like, he's just basically putting two and two together, and then it worked. It worked beautifully, and it was to everybody's surprise. And of course, we are the happiest person on the clinic front end that it worked. Yeah.
So now it's in pancreatic cancer patients, and it's a single drug.
Yes.
And it's shrinking the tumors. Like how many patients do you think are in it now?
So the study is completed. So when the study was open, it was open for patients who have gone through chemo and have no other options.
Okay.
So you give them a drug, see what happens. So that has led to a compassionate use program right now through the company.
Okay.
So we are actually trying our best to get it for our patients.
Have you gotten it for any of
your
your patients?
We are still in the process of paperwork.
Okay.
The company announced that about 2 weeks ago.
Okay.
As a single drug, it shrinks the tumor in about 25% of patients. But the remaining 80%, 25%, 70% or so, patients had stable disease, meaning stable for a long time. And it lasts for about 8-9 months.
Okay.
So it's still not a small period of time, but definitely not
Right. It's prolonging their life.
prolonging their lives. Yeah.
Okay. And you have a single drug in your lab right now.
We have that drug in our lab right now.
That's the one. So is that the one that Ethan, are you allowed to say
So
that?
that is, yes, Ethan is on a different version of the similar class of drug, on a different version, also a KRAS inhibitor. And yeah, so that's from a different company.
Different company. Okay. So just so anybody who needs a little catching up. So Ethan's wife, Jamie, and I went to college together, and we've been Facebook friends for, 20 years. And she had followed my journey and Kyle's journey, our journey, and was always in fear that her husband would get pancreatic cancer, just was in the back of her mind. They had moved to the Netherlands 3 years ago, and I got a call in January that he was diagnosed on Christmas Eve or Christmas Day with pancreatic cancer. And in the Netherlands, they only give 12 rounds of FOLFIRINOX, and then they say, it's all we can do. Right? There's not studies going on in the Netherlands. It's not sure.
Not sure what setting it was.
It's socialized medicine over there.
Okay.
So then Jamie called me and said, what do we do? And I said, let me get in touch with Dr. Lim. And so then we got Dr. Lim in touch with the Luths, and very quickly you said to them, we have more here in the U.S. You were confident that you could do more than just 12 rounds of FOLFIRINOX. So then they moved back from the Netherlands and started seeing you. And after one round of chemo, maybe, you were able to get him in one of your studies.
Yes, one of the KRAS inhibitor study.
And initially you got him in and missed it by 5 minutes.
Yeah.
Are you allowed to talk about this?
Yeah. Sorry. So it was a clinical trial. At the time, daraxonrasib was nowhere near being approved. We didn't have the data yet. So we didn't know what the outlook was for that drug. But there were but the data was out there in the conferences, and a lot of companies that basically developed their own versions of KRAS inhibitor. So this particular company had one, and we've been working with them for a long time. And they had a drug that we knew was working for some patients. And they were opening, they opened different dose level, and they are not, at the time when I talked to Luth, they had just opened up 1 or 2 slots, and they said you got to grab it by the end of the day. So I remember what was I doing. When I saw the email, I was kind of in a conference call. I basically just called him and say, "You interested?" And he said he was.
Asked Ethan if he was interested in being in the study.
Yeah, and they say he was, and I just grabbed the slot, and I know at the time that it was in the right dose.
But you initially went to grab the slot and you missed it.
Yeah.
By 5 minutes.
Yep. And they were giving me some time to grab it, and then they said, if you have a good patients and who's committed and who's robust enough, they'll give it to us.
And they did.
Yeah, they did. Yeah.
So initially you had to say, Ethan, do you want in? He said he wants in. We missed it by 5 minutes.
Yeah.
Then you and I had that meeting with your team. And you told me, you looked at me in the eye and said, I'm going to do everything I can to get him in that.
Yeah.
So I called Jamie and said, unbeknownst to you, called Jamie and said, Dr. Lim says he's going to do it. And I believe him. And he called her the next day and he was in.
Yeah.
And it's working.
It is. Good.
Yeah. The last,
I saw scan.
His tumor marker is down, I think 11%.
Yeah.
11% after the first round, or for a couple rounds. So it's amazing. And Jamie, and it's my age. We're in our 40s, and they have young kids, and there's hope.
Yes.
And I have another patient friend that's coming to see you on Thursday, and she and her husband wanted to meet yesterday, so I sat and met with them. And I am not a medical expert. Okay, I was in marketing, sales. I am not a clinician. I know enough to be dangerous, I think, in pancreatic cancer because of Kyle's treatment and working with you. But this is a message I want to share with people, that there is hope. And there are really amazing things happening in labs like Dr. Lim's right now. And we do need to privately fund it to the best of our ability, because if we can, everybody gives a little bit, we will move mountains in this disease. And it is on the rise. It is affecting patients younger and younger, GI cancers as a whole,
Yes.
unfortunately. So maybe you're not affected by it today, but in the future, you just never know. You never know.
Yep.
And so, I want to continue to raise awareness and funds, determined to do it just because of all that you have done and are continuing to do.
Yep.
You gave my kids an extra year with their dad of memories. And so, I can't thank you enough for what you've done and are doing.
Oh, same here. Can't thank you enough. I mean, when we started out with Kyle, it was just me and David Donato, 2 people working on it. But now we have a team. So, and we are committed to eventually beat this disease. And we start by, like I said, other than developing new science, we need to provide care for our patients in the surrounding area. That's also something that's very important for me. I think everything that we raise here will fund meaningful rep research. Like I mentioned to you, I don't do descriptive research, like describing how bad the problem is, and there's importance to that, but I already know how bad it is. I just don't need to know in different ways how bad it is. We need to find solutions. So the kind of research that we do in the lab are to find new treatments, how to make it better. And the important thing is not in mice. It has to go back to patients. So that's our mission, and that's what I want you to know, where the money will be used.
So what else can I do? What else can people like me who have lost our husband and Jamie who are currently battling?
Yeah, I think supporting each other, that's really important. And this is still a very dreadful disease, and we are finding ways to battle it. And many people in the country are doing the same thing. We're joining forces. The important thing is for the family and to going through that, to support each other. And I sound like a broken record again, but don't forget to live. There are still people who are alive who needs attention, and they need to go on and with great memories of the ones they've lost. And then that's how we go on.
Yeah.
Yeah.
So I always ask my guests at the end of the podcast to tell our guests one thing that they want to take away from our podcast today and what we've talked about. Would that be it for you? To go live?
Yes.
Live while you can.
Yeah, live while you can.
Okay.
And appreciate people around you.
Yeah, because you never know.
You never know.
Well, thank you so much for coming on the show today, Dr. Lim. I really appreciate your time. I really do. I know you're a busy man.
No, well, thank you for having me. I'm honored. And
Yes.
I'm really happy to be here.
Well, thank you again. And we will continue to work together and continue to move the needle here because, it matters. It really does.
Yeah, it does. Yeah, it does.
So thank you to all of those who have listened today. Thank you to everybody who has donated over the last few years. Truly is moving mountains. And so I encourage you to, if you have any questions, please contact me. I can answer whatever questions you'd like and direct you, to Dr. Lim in his lab. And donor advised funds is, also we can absolutely use donor advised funds for the, for his fund as well. So anyway, thank you so much for listening today. We'll be back next week, 10 a.m. Central Standard Time every Tuesday. We'll see you then.
What if you could start your day feeling loose, relaxed, and ready? Deep hydrotherapy right in your backyard. Relax with your family or friends, or work out with our Michael Phelps Edition Swim Spas. Worried about maintenance? We have factory-trained service nearby whenever you need it. Plus, we're here for you long-term if you have any questions or need to refill supplies. You can even test spas at our showrooms. Spas and More, A+ rated, locally owned for 20 years. We put the in spa.